Again, my name is Kathryn Carroll. Much better. Again, my name is Kathryn Carroll. I'm a policy analyst at the Center for Disability Rights. The Center for Disability Rights thanks the committee for inviting us to give testimony on Assembly Bill 2383 at this critical time. The Center for Disability Rights is a disability-led, not-for-profit organization. CDR advocates for the full integration, independence, and civil rights of people with disabilities in an independent living framework. We also work for national, state, and local systematic change to advance the rights of people with disabilities. As an organization that both employs and serves many New Yorkers with various disabilities and advocates for all disabled New Yorkers, CDR can ably comment on the experiences of living with a disability and how proposed law and policy such as this would impact us. Assembly Bill 2383 and bills like it are dangerous for many reasons and should not be permitted to proceed. Proponents of 2383 frame their argument around increasing individual choice, but the disability community is concerned with losing our choice to live, which is why organizations like the Autistic Self-Advocacy Network, the New York Association on Independent Living, the American Association of People with Disabilities, ADAPT, the ARC of the United States, TASH, the Disability Rights Education and Defense Fund, the National Council on Disability, the National Council on Independent Living, the National Spinal Cord Injury Association, Not Dead Yet, and United Spinal all oppose assisted suicide. This bill allows opportunities for mistake, coercion, and abuse. Disabled people are at greater risk of coercion and abuse, and if even one person died of assisted suicide under these circumstances, it is one person too many. The committee should regard this possibility as unacceptable and Assembly Bill 2383 as inherently flawed. CDR would like to bring to the committee's attention three concerns. First, the reasons given for seeking assisted suicide are typically related to disability going unaddressed by services and supports. Second, the requirement that a candidate for assisted suicide be terminal cannot be narrowly applied. And third, an individual's economic situation will undoubtedly influence their end-of-life decisions. Regarding the first point, although intractable pain has been emphasized as the primary reason for enacting assisted suicide laws, the top 5 reasons Oregon doctors actually report for issuing lethal prescriptions are the loss of autonomy, being less able to engage in activities, loss of dignity, loss of control of bodily functions, and feelings of being a burden. These are disability issues, and the way to address these issues is not to offer a way out, but to provide adequate services and supports. Having adequate attendance services, for example, would alleviate feelings of being a burden and give someone the personal care assistance and support that they need to live their life independently. And I want to note that in this way, proper services and supports for disabled people are an effective form of suicide prevention because they provide aid in living. We should be focused on dignifying people's lives rather than trying to dignify their deaths. Proponents of assisted suicide claim that these bills do not target people with disabilities because assisted suicide is only available to the, quote, terminally ill. But I'm here to tell you that not every person with a disability is terminally ill, but every person who is terminally ill is or will become a person with a disability. The idea that disability acquired as the result of illness is as cause enough to end one's life is a devaluation of our lives and is offensive to us. On the subject of actual pain, Hospice and palliative care exist for end of life. These services should also be expanded. Anyone dying in discomfort that is otherwise not relievable is able to receive palliative sedation, wherein the patient is sedated to the point where discomfort is relieved while the dying process takes place. We have a legal solution in place to deal with intractable pain. My second point today is that the requirement of being terminal will be applied broadly. Again, proponents of assisted suicide argue that it's a process that's only available to people who are terminally ill, implying that we're talking about a very narrow population. However, I want to refer you to, in my testimony, in my written testimony, a dialogue between Fabian Stahl and the Oregon Health Authority. And this dialogue indicates that many more people than we are led to believe may actually be considered terminal and therefore candidates for assisted suicide. And this is based on the implementation of the law in Oregon. Mr. Stahl asked the Oregon Health Authority that if an eligible patient, if a doctor suggests to an eligible patient that a treatment could possibly prolong their life, turn their terminal illness into a chronic illness, or even cure their disease, but the patient doesn't give his or her consent to the proposed treatment, would they still be eligible? And then similarly, if a patient with a chronic disease for some reason decides to opt out of their life-sustaining treatment, and by doing so is likely to die within 6 months, transforming their chronic disease into a terminal one, would they be eligible? And the answer to those questions was yes. Going further, Mr. Stahl asked these same questions, but this time the reason given for not consenting to a treatment or opting out of a treatment was that the patient's insurance company would not pay for it. And again, in that situation, the answer was yes, those people would be eligible. So just because their insurance company would not cover some other treatment, they would be qualified for assisted suicide. And I want to quote the Oregon Health Authority here. Patients suffering from any disease may not be able to afford some treatments or medication and may choose not to pursue some treatments. And in this case, ending the quote, they would qualify for assisted suicide. So in summary, on this point, the law on which Assembly Bill A2383 is based permits people who opt out of treatment or cannot get treatment to qualify for assisted suicide. My final point today is that economics preclude actual choice. We need to think about assisted suicide in the context of the profit-driven healthcare system that we live in. Insurance companies have tremendous power. The cost of a lethal dose of drugs typically used in assisted suicide is much cheaper than the cost of long-term medical treatment. So we have an incentive to save money by denying treatment. And this already poses a significant danger today, and we're sitting here considering a bill that would make that incentive stronger. The influence of a profit-driven healthcare system should be clear enough, but sadly there are examples of people being denied treatment options, but being offered the opportunity to kill themselves. And I refer you in my testimony to the situations of Barbara Wagner and Randy Stroop. Barbara's doctor prescribed a medication to extend her life in the face of lung cancer. And the Oregon Health Plan notified Barbara that it would not cover this treatment, but it would cover, among other things, assisted suicide. In Randy Stroop's case, he was prescribed chemotherapy for his prostate cancer, which would have decreased his pain. Randy's insurance would not cover the chemotherapy, but would have covered assisted suicide. When you are denied options, where is your choice? Beyond our broken healthcare system, not all families are able and willing to financially provide the services and supports that their relative needs. Whether intended or not, some patients will feel that they should request assisted suicide so that they will not be a financial burden on their families. And this brings me back to my earlier point that services and supports for people with disabilities need to be expanded to give people the choice to live their lives independently. You cannot argue that there is not an economic incentive on the part of insurance companies or families and caregivers to contemplate or even encourage someone committing assisted suicide. As long as these external influences exist, the promise of a choice to end one's life is a lie. People with disabilities are already contend with the stigma and ableist belief that our lives are less worthy than others. Legalizing assisted suicide would reinforce that idea that living with a disability is a perfectly good rationale to want to kill oneself. The promise of choice and control is a lie. There can be no free choice to die without a free choice in where and how we live. Discrimination, lack of access to good health and palliative care, and inadequate in-home services and supports limit the quality of life of the elderly and disabled. Allowing these problems to continue creates a coercive and desperate situation for disabled people, pressuring them to choose assisted suicide. Again, the broad applicability of the terminal requirement means that many people who would not otherwise be terminal, but for opting out of treatment or being denied treatment, suddenly they qualify for assisted suicide. The Center for Disability Rights urges the committee to consider the grave unintended consequences of what is being proposed, vote no on Assembly Bill 2383, and instead work to increase access to the services and supports people need to live their lives in freedom. Thank you.
Thank you. I have one quick question. In your testimony, you mentioned the availability of palliative sedation.
Yes.
Does the Center for Disability Rights support the current legal availability of palliative sedation?
Absolutely. That's something that we believe should be available to people.
Okay.
And like I said, that's the legal solution to, the currently legal solution to helping someone deal with manage their pain.